conversation. And to everyone tuning in, please stay engaged, use the chat box, share your thoughts, your questions, and let's make this an interactive and inspiring session that moves us from dialogue to real action. Once again, thank you for being here and welcome to what promises to be a powerful and inspiring event. I will be introducing to us Dr. Adekpeju Adeniran. She's an experienced clinician and a public health physician. She's the co-founder and chapter lead of the Women in Global Health Nigeria, where she leads initiatives and advocacy for gender parity in global healthcare leadership in Nigeria. She was formerly the Health System Strengthening Lead on the Universal Healthcare Access at the Lagos State Primary Healthcare Board, a BMGF-supported project. Dr. Peju leads health services delivery and advocacy for marginalized populations, initiatives for equal rights, and she ensures that health systems focus on equity in health delivery. You're very welcome, Dr. Peju, and you have the center stage.
Thank you very much. Can everyone hear me?
Yes, we can.
All right. Good afternoon, everyone. The Director General of the National Health Insurance, ably represented by the Deputy Director and Technical Advisor to the NHIS, representatives from government agencies, development partners, our colleagues in global health, a vibrant community of advocates, distinguished guests, ladies and gentlemen, we're indeed very honored to have you here today. On behalf of Women in Global Health Nigeria, I'm deeply honored to welcome you to today's timely and powerful conversation. It's titled Raising New Voices, Preparing Women's Leaders to Drive Nigeria's Universal Health Coverage. Today's dialogue is special, not just because of its theme, but because it represents the very essence of our mission. We're creating spaces where women don't just sit at the table, but they shape the agenda with clarity, courage, and conviction. Universal health coverage is not merely a policy target, it is a moral and collective commitment. It's a promise to every Nigerian, regardless of their gender, location, or income. They deserve to have access to quality healthcare without financial hardship. Yet, to turn that promise into progress, we need inclusive leadership that listens to communities and understands lived experiences and realities, and then takes decisive action. And that's where women's leadership becomes indispensable. Across Nigeria, we have seen young women step forward through platforms like EmpowerHER Health Fellowship, using advocacy, research, storytelling, and digital tools to shape the future of health equity. I'm very, very proud to have 5 of our fellows today. And it's proof that when women are equipped, they transform systems. As we begin, I invite us to reflect on one question. How can we build a health system where leadership truly represents the people that it serves, being inclusive, equitable, and transformative? Thank you once again for joining us. Let's raise our voices, let's share our stories, and together, let's shape a stronger future for universal health coverage in Nigeria. Thank you.
Thank you very much for that, Dr. Adekpeju. A wonderful welcome address. I love that you said, inclusive leadership is one that listens to communities. And it goes without saying that today's event is true representation of inclusive leadership. We intend to listen to the communities of women and elevate their voices. I will be introducing to us Leslie Udoh. Leslie Udoh is the marketing and communications specialist for the Women in Global Health Nigeria chapter. He leads the creation of high-impact content and campaigns that amplify women's voices and drive gender equity in the global health space for the Women in Global Health Nigeria chapter. Through strategic storytelling and digital engagement, Leslie ensures that the organization's messages resonate with communities that are far and wide. He's not just a storyteller, he's a media advocate who is shaping the future of health communication. Leslie Udoh, you're very welcome, sir.
Thank you very much, Hadiza, for that warm welcome. Good afternoon once again. distinguished guests, and colleagues. So I will be taking you through Women in Global Health, Nigeria's EmpowerHER Health Fellowship. And I'm going to begin by saying that this fellowship is one of the flagship programs launched with one clear vision, which is to create hyper-visible Nigerian women leaders in global health. And very much proudly, I can tell you that we are beginning to see this vision come into fruition. I'll tell you how, but first, let's walk through our journey. You can see all of our fellows on your screen right now. So we began this fellowship in April 2025 with 24 remarkable women from diverse regions and professional backgrounds across Nigeria. And each of them brought with them her story, a passion and a vision. And through this fellowship, we sought to give these visions structure, a voice, and of course, power. And one thing that we considered in our thought process in developing this fellowship curriculum was designing 4 focus streams, and each of them allowing our fellows to flourish in their respective fields. We have advocacy for change, where fellows learn to influence systems and policies through evidence and storytelling. And this stream, as you can see, is taken by all 24 fellows. We have the social media for impact focus streams, where fellows discover how to use digital tools to drive conversations and spark social change. This particular focus stream is taken by 8 fellows. We have the research for gender equity stream, which equips fellows to ground their advocacy in data and evidence, also taken by 8 fellows. And lastly, we have the speaking for leadership and personal branding focus stream, where fellows learn to find their authentic voices and, of course, strengthen their public identities as advocates and leaders. Now, moving on to our methodology, thank you. It is very, very intentional and deeply people-centered. What we did was we began with a 3-day in-person lunch in Abuja, which was very much filled with energy, learning, and a lot of collaboration between the fellows. And I would say that that session actually set the tone for the entirety of the fellowship. That session was immediately followed by weekly virtual sessions between May and October 2025 with 4 facilitators leading real-time case studies, lectures, and collaborative tasks between the fellows. One unique aspect of this fellowship I should mention is that beyond the training, beyond the virtual sessions, each fellow engages in a one-on-one mentorship session with their facilitator. And this in turn creates a very nurturing environment that allows every fellow to grow with personalized guidance and accountability in their advocacy work. And of course, I would say the results speak volumes. As you can see, just a few to mention. Our fellows have collectively published over 8 articles on leading media platforms. They've been able to gain both national and international recognition and produced over 100 advocacy posts that have reached thousands of people across several digital platforms. But beyond these numbers, what truly stands out is the transformation. We've watched women who once hesitated to speak now command rooms with confidence. And if you want to have a view of this, I would advise you go on our social media pages and look at the transformation of these fellows. We've seen them use their voices to tell stories that drive policy conversations and, of course, inspire real change. And just a footnote, EmpowerHER is not just a program. What we are building is a movement, and one that is reshaping how women show up in health leadership, how advocacy is done, and how gender equity becomes a lived reality within our health systems. Thank you very much. And I'll hand it over to you, Dr. Hadiza.
Thank you so much for that, Leslie. Just looking over, looking over this entire presentation and looking around and seeing the faces of all these beautiful women that are leading change in the global health sector, I'm truly honored. For those of us who don't know me, Dr. Hadiza Thompson, who is the Doctor on Air brand, I also happen to be a beneficiary of the Empower Her Health Fellowship. I'm actually in the Speaking for Leadership and Personal Branding stream, focus stream. And courtesy of the Women in Global Health Nigeria chapter, I happen to be having the greatest honor of moderating this all-important event. Thank you so much, Leslie. I mean, like you said, the results do speak for themselves. I think it's so evident that we're leading a lot of change. We're leading positive change as the Women in Global Health chapter. Very quickly, I will be introducing to us Dr. Olayinka Badmus. She's a distinguished public health professional, a gender advocate, and a social behavior change expert with almost 2 decades of experience in advancing health equity across Africa. Dr. Badmus has served as the Deputy Project Director for the USAID-funded Breakthrough Action Project, where she guided national efforts to mainstream gender and equity in epidemic preparedness and response. Dr. Olayinka is the founder and convener of Echoes of Her. It's an intergenerational storytelling platform that amplifies women's voices and lived experiences to drive social change. Thank you so much, Dr. Olayinka, for being in our midst. It's truly an honor to have you, and we'd love to hear your story and how we move, of course, from lone voices to actual change. Please, you have the stage.
Thank you so much, Hadiza, and good afternoon, everyone. It's really a pleasure to be here and to have this conversation, which is not just deeply personal. As a professional who has spent years working in street health system strengthening, but also as a woman who has lived the very realities we are here to transform. I've navigated spaces where mentorship was scarce, witnessed how families, break under the weight of health costs, as well as the urgency to build a system that works for everyone. 18 years ago, I was thrust into the leadership of managing a health maintenance organization in Southwest, specifically, Lagos. This was with barely any mentorship or roadmap to guide me. I was thrust into a pool of, really dominated by older men, if you know the health insurance space, and it's still dominated by older men. I did a lot of learning by doing, being the pioneer staff. I went back some few months ago and I was like, if pictures were going to be on the wall, my picture would be the first on this wall. Building systems from the scratch, from claims management tools, to determining our client provider engagement model and retention strategies. I made sure that we were turning out retention. And overall, we really grew from no enrollee to tens of thousands of enrollee and a very strong revenue. And it really felt like success. I had arrived. I had done my MBA. I was on top. And by 2013, I saw the bigger picture. Only 2% or less than 2% of Nigerians had any form of health insurance coverage. I was devastated. And I asked myself, Olayinka, what exactly are you doing? Do you understand? What are you contributing to? And it was a moment of self-reflection, asking myself, is this what you meant when you said you wanted to save lives? And what exactly was your core purpose? That question changed everything. I left my comfort zone. I was a regional lead. I had a car, I had an office, I had a secretary, I had the works. And I got up one day and I left. And I left and I started sitting in a cubicle. It was a mental shift for me, being there and then coming back really way down to start all over again. But I had a purpose. Why was the system failing so many people? And what have I learned over these years? Nigeria health system is complex and deeply inequitable. And I'm reminded that a few weeks ago, my aunt was in hypertensive crisis. And a day or so before, I had seen this video of FCT's emergency transport, emergency medical services, just call this number. It's like, Nika, do you want to call that number and call an ambulance to come and pick her? I said, if you don't reach the hospital in the next 30 minutes, this woman is gonna have a stroke. And so I picked up and I drove out to the hospital that I normally use and entered I knew where I was going, so I went straight to the emergency room. I knocked on the door, nobody answered me. I went back to the front desk and I said, is it until, everybody shouting emergency, running here, blood, ambulance rushing in before we know we are in an emergency? And so they called the emergency room and asked me to enter. And I said, my aunt is in a hypertensive crisis, and they checked her BP. It was 200/109. And before I could ask to do anything, I was asked to go and make payment. I got to where I needed to make payment, and I was told emergency consultation is 120,000. I was shocked. This is the same hospital. I go in, walk in with my card, show my card, and I get service. This is the same hospital. I'm coming in with somebody else who does not have financial protection, and emergency service is 120,000. In short, this life is not balanced at all. And so at that particular moment, it became full circle to me that from trying to understand the why to where change must happen. Change will happen, will take root when, our collective power to build together. Because no single person, no matter how passionate or skilled you are, can move the UHC agenda forward alone. It's going to take new voices, shared vision, and collective power, the kind that EmpowerHER is nurturing, reimagining leadership, reframing strategies, and bringing universal health coverage within the reach of every woman. So as we begin today's conversation, I invite you not just to listen with your minds, but with your hearts, and to imagine, what becomes possible when our individual journey meets a collective purpose. Thank you very much. And I hand it back to Hadiza to take us through the remainder of the session. Back to you.
All right. Thank you so much, Dr. Olayinka, for that. I mean, I agree with you, and I believe all of us present in this webinar agree that it would take collective action, not just one person. One of the things we are being taught during our EmpowerHER Health Fellowship sessions is that advocacy a lot of times outlives us, and we must continue. Whether or not we see the change immediately. And that is exactly what we're doing right here. Thank you again, Dr. Olayinka. Very quickly, we will be going into the keynote address by Dr. Kelechi Ohiri. Dr. Kelechi Ohiri is the Director General for the National Health Insurance Authority. And I would just give us a little bit of an introduction into who he is. Dr. Kelechi Ohiri has extensive experience in public and private healthcare sectors, spanning clinical medicine, health policy, finance, management consultancy, and advisory roles. Before his appointment as the Director General and Chief Executive Officer of the NHIA, he served as the Chief Strategy, Policy, and Innovation Officer for Gavi, the Vaccine Alliance. Having previously held the position of Managing Director for Policy, Program Policy and Delivery Support, he also served as the Chief Executive Officer of HSDF, a healthcare advisory firm, and as a visiting scientist at Harvard University. He is a Desmond Tutu Fellow of the African Leadership Institute and a member of the Aspen Global Leadership Network. Today, Dr. Kelechi Ohiri is ably represented by Dr. Nennaya Kalu-Ume, the Deputy Director and Technical Advisor to the DG, National Health Insurance Authority. Thank you so much, sir, for honoring us with your presence.
Thank you so much for having me, Hadiza. It's a pleasure to be here. First of all, let me start by thanking you for the opportunity for inviting NHIA to be part of this. The Empower Health program is really something that I believe is, like you said, it's not just a program, but it's building a momentum. It's building this, this leadership of women, this cohort that can make a lot of change and can really move the needle when it comes to women's leadership and changing the health outcomes in Nigeria. So I'm going to be talking on strategic government efforts to advance gender equity in health and also to achieve universal health coverage in Nigeria, mostly from the demand side perspective in health, but I'll try to carry everybody along. Next slide, please. Right, so there's a strong link between health, gender, and development, right? I mean, it's really important that we remember that a lot of women face barriers when they want to access health. Sometimes it's related to their gender. And when health is affected, it also affects productivity, which also in turn affects development. So they're really linked. And when we look closely at our country, Nigeria, even though we have a population of 200 million and above or more, we should be able to drive productivity and drive development. When you look closely at that figure, a lot of them are women, 49.95%, that's about half. However, when you look at it again, a lot of these women are not as productive as they should be. We have a large informal sector economy. And I don't know how many of you have seen the informal sector economy report of 2025, recently released by MoneyPoint, the Federal Ministry of Industry and Trade, and also SMEDA. If you look at that report, it says that the informal sector economy is contributing to more than 65% of the GDP of Nigeria, right? And more than 80% of the jobs that drive this economy are found in that informal sector economy. Women are more likely to be employed, but only 35% of those businesses are owned by women. So there's already that disparity. And then, of course, I don't need to talk much about the high maternal mortality rate and also the high out-of-pocket expenditure for health in Nigeria. And also, again, the significant multidimensional poverty that we have. So all these are factors that contribute in one way or the other to affecting the health of Nigerians, especially women. Now, coming to gender equity and health, this is what we're here to talk about. We chose to look at it first from the point of inequity, because the inequity contributes to poor health outcomes. And there are lots of issues that we need to talk about. There are access issues. A lot of women lack decision-making power. How does she know that she has a health issue? How does she know that it's serious enough for her to go and seek help? And how can she even decide to go and seek help when she needs permission from maybe an older family member or a husband or somebody else? The distance to the facility could be another barrier. Geographical distance. I mean, ideally, everybody should live like at least 30 minutes or less than 5 kilometers to a functional primary healthcare facility that can give them all the care that they need. But how many of us have access to that? Opportunity cost is something that we don't always think about. I mean, we're talking about access. Okay, we usually think about the functional, the financial, the geographical. Opportunity cost. A lot of women are caregivers. They have their small businesses that they run. They have their children they look after. They have their caregivers to older people. And anytime it comes to taking time off to take care of themselves, they look at the opportunity cost. What am I losing? Do I need to leave my children? Do I need to leave my business? The money I would have earned for the day? They think about that. And sometimes they deny themselves the care that they need. And of course, poverty. I'm sure a lot of us already know about poverty and ill health, the nexus, and how they contribute to each other. Now, looking at system issues, that's another big driver. Now, when you don't have enough women in leadership, you tend to see that the perspectives of women are not, they're not thought about, they're not included in the design of interventions because they're not there. And you find out that even though a lot of women are in the health workforce, as you rise, you see fewer and fewer women. Dr. Olayinka talked about the Health Mental Health Organization where she worked. If you look at the health insurance industry, quite the number of women is really, really few. I was looking at a while back, not too long ago, there were about 81 health maintenance organizations. I think about 5 of them are run by women, less than 10. So you can see that disparity is really a male-dominated area. I think it doesn't just apply to health insurance. I think it's across the health sector. So women are fewer in leadership in health. And because of that, their voices may not be heard when interventions are being designed for other women, and then therefore access issues may also come up. Information issues, yes. And I'm so happy that the EmpowerHER Health Fellowship speaks to this, helping women get their voices, communicate better, carry out the advocacy that is really, really needed. There's a lot of low awareness of services, especially when it comes to health insurance. People don't know where to go, where to get the care they need. There's a lot of misinformation as well. You know, all this, they said this, they said that. If you go here, it's a lot. And people tend to rely on the grapevine, informal means of getting information. People also tend to prefer to get information in their own local languages. And so in designing, our interventions, we have to take that into consideration. Break down the language barriers, make sure that we are addressing misinformation. And literacy is another issue as well. We need to make sure that the girl child is educated. We need to make sure that they go to school, and not just go to school, that they finish school and that they understand what they are learning. So really, really important for information issues. It has a lot of impact on the health of women. And then the health risks as well. Risk of early marriages, unintended pregnancies, sexually transmitted infections, and gender-based violence. That's also high as well when you have that inequity. And then because of this early, unintended or unplanned pregnancies, and also limited access to healthcare services, you may have obstetric emergencies and obstetric fistulas. And I'll talk more about the emergencies and fistulas later, because we have an intervention that we're carrying out at NHIA that has to do with this as well. So next slide. So let's look at gender equity and how, previous slide please. Gender equity and how it contributes to better health outcomes. So we're looking at the reverse of what we looked at in the earlier slide. Definitely we need to improve access, financial access. And that was a powerful story by Dr. Lainka talking about how financial protection could be the difference literally between, having access to care in an emergency, or even between life and death. So it's really important that we need to improve access for vulnerable people, especially, and women too. And then also physical access. I talked about the distance to healthcare facilities and functional access. You might have the money, or you might have social insurance. You might be financially protected. You might be able to go to a nearby facility, but is it functional? Does it have the requisite human resources? Does it have all the equipment that it needs? Are there drugs? Are there the basic infrastructure like lights and running water and all that? That's really important when we talk about access. And I talked about opportunity cost as well. What is the cost? What does it cost the average woman to go to the facility? What is she giving up? Her business, her family, her time? Is there a caretaker either for the person who's ill and going to the hospital, or for the children she's leaving at home? Are there navigators within the healthcare facility that can help her to navigate, find her way around, and find the help that she needs in good time? So those are things that we need to think about as we work to improve access. We need strong systems. We need laws, right, that speak to improving access to healthcare. And we have quite a number of laws. I mean, the National Health Act, NHIA Act as well. So we need laws. We also need policies. We need programs that align with what we want to achieve, which is universal health coverage. We need integration of the efforts of different stakeholders. A lot of times we work vertically, but now that funds are dwindling, sometimes I think we're now being forced to think more efficiently and see how we can work together and use the limited resources that we have to achieve the results that we want to achieve. But this integration is not just within the health sector, but it's also across different sectors. I mentioned education, sending girls to school. Education is also key. Environment is key. and so on and so forth. Even social protection, we have social welfare as part of health now. And we also have a lot of interventions happening within the humanitarian space as well. So bringing all these interventions together is really important. The private sector as well. A lot of times, sometimes as government, we design interventions and we leave out the private sector. Meanwhile, the private sector deals with, or rather provides services to a lot of people. And so they have to be included in the conversation, in the process, in the framework. And then, of course, including more women in governance, in the processes, providing care and all that. We need more women. We need more opportunities for women. We need women to have voices and to contribute more. Reducing health risk. We need to shift our focus from just managing emergencies, treating chronic conditions, to our focus more on promotion and prevention. Yes, we need to do that as quickly as possible as a country. We also need to focus on health education, breaking it down from the technical jargon that we use, in big meetings to things that the man on the street can understand. And then we need to talk about family planning is really key. We need to talk about health insurance and ensure that there's uptake, there's financial protection. And I mentioned water, sanitation, and hygiene. I'm really, really passionate about this in particular because, just imagine if everybody had access to, water, good clean water, sanitation, and good hygiene would cut down the number of diseases that people come to the facilities with. And then, of course, communication. We need to improve literacy, use local languages, and leverage community champions as well. Next slide. So this is just showing you the Federal Ministry of Health and Social Welfare strategic blueprints. The goal is to save lives, reduce physical and financial pain, and produce health for all Nigerians. And there are 4 pillars you can see: effective governance, efficient, equitable, and quality health systems, unlocking the value chain, and then health security. So it's under the efficient, equitable, and quality healthcare systems that you talk about improving the quality of care and improving the equity of access, not just equity in terms of male and female, but also equity in terms of those who can afford healthcare and those who cannot afford healthcare. And at the bottom, you can see the enablers, which is data, digitalization, financing, and culture and talent. So based on this, NHIA also has its own strategic pillars, which is on the next slide. Next slide, please. Next slide. Thank you. So our goal is to bring millions of Nigerians out of health poverty, and it's similar to what you're probably trying to accomplish. And we have 4 pillars. We want to expand coverage, and we're already doing that. We have been able to increase health insurance coverage from 16 million to over 21 million in less than 2 years. We also know that during the last health financing dialogue, there was a declaration or a directive from Mr. President that all MDAs should enroll all their staff into health insurance, and the private sector should be engaged to fast track that as well. So a lot of things are happening to expand coverage. We also launched a self-service portal as well. Then under improving equity, we have our equity programs, which I will speak of in another slide. We have the BACPF, that's the Basic Healthcare Provision Fund. It's also the Vulnerable Group Fund. And under the Vulnerable Group Fund, we have a fistula-free program for women with fistula, and also one that also provides emergency care for women who are poor and vulnerable. Under improving quality of care, we've digitalized our quality tools for accreditation, and we are ramping up our interventions to make sure that all complaints are resolved. We have about a 92% success rate for resolving any issues that have to do with access to care. And then for market efficiency, we are creating a more efficient and sustainable health insurance industry for all stakeholders. And you can see the enablers at the bottom there. All right, next slide. I'll just wrap up very quickly in 2 minutes. So this is the fistula-free program. We've scaled up from 4 to 20 facilities, and we have 4,000 beneficiaries, right? And this is for women with obstetric fistulas. It covers treatment, family planning, and health insurance enrollment. For the comprehensive emergency obstetric and newborn care, it removes financial barriers, saves the lives of the mothers and babies, also enrolls them in health insurance, and gives them family planning. We have over 18,000 claims or beneficiaries and we just launched a neonatal component. Next slide, please. So what are the opportunities? Political will, I talked about the directive from Mr. President. There's global support, stakeholder commitment, and the momentum that you are creating. Financing is needed. Already Nigeria is committing finances to, even the gap that has been left by donor fatigue. We're leveraging technology. I talked about that. Intersectoral collaboration. I mentioned that. We need to collaborate with education and other sectors. Social protection system. Increasingly, we're talking about, bring everything together, not just social insurance, but also social assistance. Research and working with evidence, which some of you are already doing. Local production of medicines and equipment. We have PVAC. Reorientation towards health promotion and disease prevention, which I mentioned already. Prioritizing the other determinants of health. I mentioned WASH and all that. And then supply side strengthening, because it's important even when you provide that financial protection, people will get to the facilities and they need to see the available human resources, the drugs and other things that they need. So in a nutshell, I think that is my presentation. Thank you so much for listening.
Thank you so much, Dr. Nenaya, for that wonderful presentation. I wish we were in a physical location. I'm sure we'd hear the round of applause, but please give her a virtual round of applause. And very quickly, because our time is fast spent, I do want to reiterate that one thing that you mentioned, which was the fact that we needed to do research and work with evidence. We'll be diving into the panel session and, we're going to hear the voices of the EmpowerHER Health Fellows in actual action. If you're tuning in with us, I'm sure you can see your screen, take a look at your panelists. And very quickly, our first speaker is Dr. Funmi Adio, who fortunately for us will also be going further to show us how we can advance universal health coverage through access to obstetric care. Dr. Adio is actually a public health physician. She's in the Research for Gender Equity focus stream in the EmpowerHER Health Fellowship, and she's a public health physician. She's a researcher. She's committed to advancing UHC through her work in infectious diseases, gender equity, maternal and child health, which is something that Dr. Kalume also spoke about, obstetric fistula and getting access to for women and children. Dr. Funmi Adio is, she's dedicated to evidence-based driven solutions that strengthen Nigeria's health system and accelerate its progress towards achieving the UHC agenda. Thank you very much, Dr. Funmi Adio, for being in our midst. And I'll hand over to you and work your magic.
Thank you so much, Hadiza. I'm so excited to be here today. And let me start by saying a big thank you to Women in Global Health Nigeria. This is a huge platform for me to share my work, and I'm very grateful. So today we're here talking about universal health coverage, and you agree with me that it is a fundamental human right. It guarantees that everyone has access to quality healthcare, essential healthcare, wherever they are, without encountering any form of financial hardship whatsoever it is. However, currently in Nigeria, our statistics is showing that our maternal mortality rate currently is about 512 per 100,000 live birth. So to just put this in perspective, it means that out of every 200 a baby that is being born, you have at least one woman dying as a result of pregnancy-related complications or delivery-related complications. And evidence has shown that access to emergency obstetric care is a major factor that contributes to these statistics that we are seeing today. So in the context of maternal and child health, optimal access to obstetric care ensures that we move our UHC in Nigeria further. Now, when it comes to access to emergency obstetric care, we see this more in the rural setting. My work has been really focused in the rural setting, and we see that many of these communities in the rural region, they lack access to timely to emergency obstetric facilities. When you go there, some of these communities don't even have any health facilities that can provide these essential services at all. And over time, studies have shown that women often experience delays greater than 240 minutes before they can get emergency obstetric care. And you all agree with me that this increases their risk both for the mother and for the child. Thankfully, over 70% of the maternal deaths that we're experiencing in Nigeria are preventable when there is access to emergency, when there's timely access to emergency obstetric care. So this was what prompted me to dive into this particular area. And then we conducted this project sponsored by Google in collaboration with London School of Hygiene and Tropical Medicine. And please move on to the next slide. And the title of the project is Evidence for Untackling In-Transit Delay for Mothers in Emergency. Basically, what we did was to map the journeys of pregnant women from when they had emergencies to when they were able to eventually access the care that they required. And then what we found, what we used was we leveraged on Google's big data to harness this data. And what we found was that within the urban areas in Benin City, there's good access to emergency obstetric care. However, once you move towards the periphery, towards those peri-urban areas and the rural areas, you discover that access to emergency obstetric services becomes drastically reduced. For example, if you look towards the left aspect of your screen, you will see a community. These are pictures generated from the Google dashboard. And you'll see that in Ologbo community, you have the women, they require about 61 minutes before they can get access to a facility that can offer emergency obstetric care. So now let me put this in perspective for you. This time is roughly like the time it will take an individual to cook a full family meal from start to finish. The same time it will take someone to sit and watch a movie, or even a time that you will take to drive from one end of my town to the other. So now imagine a pregnant woman in obstructed labor, or a woman bleeding heavily, or maybe a woman convulsing as a result of eclampsia. Every minute counts for them, and every minute makes that difference between life and death, not for only the mother alone, but even for the women. And it's not only Olobo community that was found to be affected. Several other peri-urban communities were affected. So now, after gathering this evidence on Google dashboard, we decided that, okay, let's confirm that what we found on the dashboard is really the reality in those communities. So we carried out a ground truthing exercise. And we discovered that really what we found on Google dashboard was what was obtainable in those communities. Those women, there were no, so in some of those communities, there were no facilities to offer care. And at the end of the day, those women were pushed to patronize traditional birth attendants. And you know what that means? Yes, TBAs have a role to play when it comes to obstetric care, but we know that their training is really limited. And best practice is that every woman should have a skilled birth attendant during delivery. That is the best practice. Unfortunately, this is what we found in the communities. We even discovered that most of these women, even for those that were eventually able to get emergency obstetric care, they had to observe several stops. You get to facility A, and they tell you, oh, there is no healthcare worker that can attend to you. You move to the second facility, they tell you, we don't have equipment, the oxygen, the basic equipment to care for you at this point in time. Kindly move to the next one. And this women go like that. And you know that every minute is very, very important. We also went further to, interviewed some of these women in the community. What are their lived experiences when it comes to accessing care? And the same thing was found. And we know that it's when women lack access to a prompt emergency obstetric care, it will definitely have adverse effect on the outcome of their pregnancies. So what is my call to action today to our policymakers? Yes, so much is being done. Kudos to the Federal Ministry of Health and Social Welfare. They are doing so much in terms of PhD revitalization, in terms of increasing health insurance coverage, in terms of even pushing out emergency medical services. However, the gap still remains. Our women are dying as a result of pregnancy and birth-related complications. So this is my call to action. Let's focus on prevention. Is there a way we can leverage on telemedicine, on digital technology to help us triage some of these our patients, those high-risk patients, those first-time mothers or women that have multiple gestation, they have twins or triplets, they're carrying twins or triplets. Is there a way we can quickly identify these women early in pregnancy before any emergency sets in, so that once we can identify them, we'll link them to health facilities where they can easily access care, not only linking them, but relocating them to those areas so that they can easily access emergency obstetric care when they require it. Now, beyond this, those rural areas, it is important that we locate 24 hours manned PHC facilities that can provide emergency obstetric care. So the facilities should be there. They should be well equipped in terms of the oxygen that is required, the 24-hour power supply, and also skilled staff in terms of physicians, midwives, nurses, and community healthcare workers. And beyond that, we need to retain these healthcare workers. Most of them don't want to work in these rural communities. So how do we do that? It is important that we incentivize them appropriately, give them remunerations to encourage them to stay and provide this essential care for these women. My time is up. So to round up, universal health coverage begins where no woman is left behind. Even that woman in that remote sense of the remote area can reach life-saving care without fear, without distance, or without delay. When we can achieve this, then we have succeeded in moving Nigeria closer to universal healthcare coverage. Thank you so much for allowing me to share my work. Thank you. Adiza,
All
over to
right.
you.
Thank you so much, Dr. Fumi Adio. I love how much or how passionate you are about emergency obstetric care. And being that you recently received a recognition with an award of distinction in public health, I believe that you're doing a lot of good work in Edo State to advance Nigeria's UHC agenda. Unfortunately, we don't have too much time, so let's head on to hear from Fatima Gidado, who is the founder of EmpowerHER. It's an initiative dedicated to raising awareness on non-communicable diseases with a focus on women and girls in northern Nigeria. Fatima Gidado is a fellow in the Speaking for Leadership and Personal Branding focus stream of the EmpowerHER Health Fellowship by the Women in Global Health Nigeria, and she'll be making a case for sickle cell inclusion in Nigeria's universal health coverage framework, which hopes to advance the agenda and ensure health coverage for all. And of course, her vision is to grow EmpowerHER into a platform that drives impactful advocacy and creates opportunities for employment and capacity building in the health sector. Thank you very much, Fatima Gidado, for being present here. And very quickly, we would love to hear all the wonderful work that you're doing. Please raise your voice.
Thank you so much, Dr. Hadiza, and good afternoon, everyone, once again. And I'm really excited to be here today. Hadiza, please, can we go to the next slide? I'm really excited to be here today to share part of the things that I've done. And then I'm really, excited because I figured that literally we're all working towards, one goal, and that goal is accessing, proper care. Giving a woman the chance to be able to access, proper care, regardless her location and her status. And so that brings me to my topic, which is the case for sickle cell inclusion in Nigeria's universal health coverage framework. And so the problem is simply because we understand the high burden of sickle cell in northern Nigeria, and not just northern Nigeria, but Nigeria in large, and how, these numbers are increasing, day by day. And so the Nigerian health system continues to leave sickle cell patients behind. And we have approximately around 150,000 babies or kids born annually, that are sickle cell patients. So, but with this condition, the patients, the patients are not classified as, they're not classified under the vulnerable group fund under the National Health Insurance Authority. And so why this matters for universal health coverage and women is simply because we understand how families face so much financial burden when it comes to health, but more especially when it comes to sickle cell. And for women, it's more because, they have to pay for transfusions that they're always getting. Their drugs are pretty much expensive. They have to pay for hospital care, and mostly they do this without, insurance coverage. And so this brings me back to something when Dr. Olayinka was talking, and she shared a very provoking situation that happened at the hospital. And that's the reality of most people in Nigeria. And that's just, a random Nigeria. So imagine, people that are born with sickle cell disease, and this is what they face on a regular basis. They have to always be in the hospital for transfusions, and the like. So sickle cell disease is both a health and financial equity issue for us. And I strongly believe that we cannot achieve universal health coverage if we keep leaving our sickle cell patients behind, because they get to, bear these out of, pockets cost. Next slide, please. And so part of the things that I have done at EmpowerHER, or I continue to do, is raise awareness. So we try to, Dr. Kalu mentioned preventive, aspect of this. We also have to look at how you can prevent these things by raising awareness, talking to people about how, they could prevent it. Because sometimes it's not about, it's not about reactive procedures, but you have to be proactive about it. So we raise awareness, go to secondary schools, talk to students about sickle cell, what it is, and how to properly, avoid, giving birth to kids with sickle cell disease. Then we have quite a number of community engagements. We go on radio to talk to people, talk to them using languages that you understand. They call in asking questions, and we answer based on, their what they want to, clarify on. And that's also pretty much important, because for everything that we do, community engagement is at the forefront. Then blood donation advocacy, we're promoting, the need for sustainable blood banks. And I would like to draw a scenario here for you. An average sickle cell patient goes to the hospital quite often, and they need blood transfusion. And sometimes they get as much as more than 3 pints of blood. And the average human, or average, average adult can give only 3 pints at most in a year. And so try to imagine if a sickle cell patient is just left with family members. These family members get tired of always going to the hospital to donate blood. And sometimes the bloods are not even compatible. So they are left with no option but to sometimes buy this blood. And then it just doesn't even stop there. The screening of the blood, the transfusion, and, the service charge that they pay, these all accumulating, when you accumulate the money, leads to quite a number of, quite some amounts that could be very burdensome on families that barely, survive on less than 30,000 naira in, here in the north. So these are, the reasons why we're really advocating for blood donation. And then also we're trying to raise awareness on insurance, make people understand that they could actually utilize health insurance schemes like the NHIA that I know covers quite, some aspect of that as well. Next slide. So what are the barriers in blood and non-communicable disease care that we have? We have the low blood donation culture, which we're trying to address that by raising awareness and trying to, create for more blood drives, events, and, blood banks. Then we have a policy gap. We have a limited financing, and stigma and misinformation. So what are the opportunities here that we could leverage on? We already have an existing vulnerable group fund mechanism where the NHIE has selected certain categories of people that get to benefit from this. So the NHIE Act gives, NHIE the power to define new vulnerable groups, a perfect window where sickle cell patients could actually be part of. Next slide, Hadiza. And so today my call to action is we're formally, asking that the NHIE should classify, the sickle cell patients as vulnerable group under the vulnerable group fund. And this will ensure that their drugs and care are being subsidized. Thank you very much.
Thank you very much, Fatima Gidado, for that. Thank you for making such a good case for sickle cell inclusion in Nigeria's UHC framework. I do hope that the representatives from NHIA were listening very attentively to you, and we should expect that after this case you've made, that in fact they should win and be included. Again, we'll be listening to Prudence Enema, who is also a fellow in the EmpowerHER Health Fellowship by WGH Nigeria. Prudence Enema is actually in the social media for impact focus stream. And Prudence is a health advocate. She's a storyteller and communication strategist who's committed to advancing universal health coverage by placing people at the center of healthcare. At Nigeria Health Watch, she develops strategic communication initiatives, including campaigns, articles, and advocacy toolkits that focus on bridging policy and community through evidence-based storytelling. Prudence will be speaking on communication barriers to universal health coverage for Nigeria Nigerian women. She remains dedicated to promoting equity, accountability, and a stronger health system through communication that informs, inspires, and drives positive change. Thank you very much for being with us, Prudence. And please, without further ado, let's hear from you.
Thank you so much, Hadiza. It's good to be here. I think Dr. Nenaya already set the tone for my presentation when she spoke on improving communications during her presentation, because health communication is more than just information exchange. It's a key driver of health behavior and outcomes. And for women, especially in Nigeria, access to clear, timely, and understandable health messages can determine whether they seek antenatal care, delivery, or recognize danger signs early. And in the context of universal health coverage, the topic for which we are gathered today, women make most of the household decisions, from what to seek, what care to seek, what child gets vaccinated, and even what food is served in the home. Yet they are often the least informed due to lower literacy levels, limited internet access, and social behavior barriers that restrict their autonomy. Um, when communication fails, health-seeking behaviors fail as well, leading to missed care, poor self-management, and a lot of preventable deaths. Written health communication have such as pamphlets, posters, and long-form outlines, still dominate outreach efforts. These formats assume that every Nigerian woman can read, process what they are passing out, and understand it and actually act on it. But for many Nigerian women, this is actually not the reality. According to UNESCO, Nigeria has one of the largest literacy gaps in Africa, with over 60% of adult women lacking basic literacy skills. This means a large proportion of women are automatically excluded from written health campaigns, no matter how accurate or well designed the message is. So while written communication remains the most common approach, it fails to meet women where they are, and health information cannot save lives if it's not understood. Next slide, please. Recent data by Gomez Consult has shown that Nigeria is a mobile-first country, and with over 172 million mobile subscriptions, which means 35% of adult women in the country use mobile internet. And across Nigeria, governments and NGOs are now sharing maternal health reminders, vaccination updates, and even myth-busting messages through social media platforms like Facebook, Instagram, and WhatsApp. I'll give an example. Let's throw back a little to what Facebook did in 2021. They did a social media drive allowing women to add frames and graphics to their profile on Facebook, Instagram, and saying they have either vaccinated or plan to get the COVID-19 vaccine. Now, these efforts have expanded reach, especially among urban and peri-urban women, and it was shown by their metrics. But these channels rely on internet and smartphone access, which excludes 75% of women in rural or low-income settings without mobile internet. To close this communication gap, Nigeria needs a blended model that combines social media reach with mobile voice and SMS inclusivity. Evidence from multiple studies by NIH and WHO in low and middle income countries show that SMS and interactive voice responses improve antenatal attendance, vaccination rates, and even maternal outcomes. These interventions are effective because they reach people where they are, using the devices they already own and in languages they understand. We did well, we've done well in the past, but there are strategic things we need to do better. And the first is we must leverage social media strategically. We must continue using platforms like Facebook, Twitter, WhatsApp, Instagram, and even TikTok. Yes, but pairing them with low data formats like SMS and IVR to ensure no woman is left behind. because we have the 75% that are not on social media. Secondly, we need to prioritize user experience. Health communication must not only exist, but it must also be usable. An SMS reminder intervention by BMC showed that there is need to localize content, simple messages. Dr. Nenaya as well mentioned avoiding jargons during communication. And yes, avoiding scientific words that the regular Nigerian does not understand would help them, process and better understand the messages that are being sent to them. Thirdly, we must build on what works. We need to scale tested models, not new experiments. Yes, we can introduce the new experiments, but we do need to scale up the ones that are already existing. We have mHealth Nigeria's mobile SMS reminders for antenatal care and immunization. We have Hello Mama's project. We have BMC smart messaging and lots more that need to be upscaled. To conclude, we are not reinventing the wheel. Nigeria has already tested what works. Combining the reach of social media with accessibility of SMS and voice messaging, and by designing messages that fit women's languages, literacy level, and realities, we can make health communication truly inclusive. Because universal health coverage isn't universal if women cannot understand, access, or even act on the information they are being given. Thank you so much.
Thank you very much, Prudence, for that. Please let's give a virtual round of applause. I believe that our speakers so far have done an amazing job of translating the evidence that they have into real action. And thank you, Prudence, for constantly ensuring. I mean, you did highlight one thing, which is communication is not done if the receiver does not understand it. And I mean, we can see evidently how the EmpowerHER Health Fellowship is truly empowering us, and we're able to even leverage on social media to create positive impact. This is not the end. We're moving to our last, but certainly not the least of our speakers, Dr. Olufemi Mulka Ajagun Ogunleye. She is in the Research for Gender Equity Focus stream in the EmpowerHER Health Fellowship in the Women in Global Health Nigeria. And Dr. Olufemi will be talking to us about advancing universal health coverage in Nigeria through nutrition-based prevention of depression and anxiety. Just a little background on who Dr. Olufemi is. She is a researcher and a lecturer working at LASUCOM. She champions gender-responsive research in nutrition, brain health, and healthy aging. Dr. Olufemi empowers young women through her research hub and advocates for inclusive mental health and universal health coverage. She's a fellow, like I said, with us in the EmpowerHER Health Fellowship, and today she'll be walking us through how it is, in fact, that we can advance Nigeria's UHC agenda. Dr. Olufemi, please share with us some of the insights from your amazing work.
Thank you very much, Dr. Hadiza. Thank you for the generous introduction. And thank you for giving me the opportunity to present my research work on advancing inclusive mental health in Nigeria. So the problem here is the prevalence of depression and micronutrient deficiency in Nigerian women. First of all, what is mental health? Mental health is the foundation of good health and well-being. Yet in Nigeria, it has remained critically underserved, basically due to a severe shortage in mental health professionals. And this is what has made mental health very expensive in Nigeria. So looking at the broad spectrum of mental disorders that we have in Nigeria, we can see that there's a high prevalence of depression and anxiety, and women are disproportionately affected. So this is the reason why I have decided to focus on depression and anxiety in women. Research has also shown that 30% of new moms usually go through postpartum depression. And reports have shown that in secondary school, adolescent girls already show symptoms of depression and anxiety more than boys in a ratio of 60.5% to 39.5%. Food and nutrient insecurity is another burden on women. Okay, women are the caregivers in the home. So the burden of food insecurity on them because they worry about when or what to give their children. Also, as a result of reproductive life demands, over the years, women tend to become depleted of essential micronutrients. And also, as a result of sociocultural norms, societal expectation, women tend to put others before themselves. And as such, they eat last and they eat least. All of this subject women to micronutrient deficiency, which takes a toll on their mental health. So research has shown that deficiencies in all these macronutrients affects the mood, and it leads to depression and anxiety. My research work focuses on the gut-brain axis. I'm looking at the relationship between what people eat and the mental outcome. Okay, the gut-brain axis is a bidirectional communication between the gut and the brain through neurotransmitters and neural circuits. So these neurotransmitters are the ones responsible for proper brain coordination, and they are basically produced in the gut. Okay, they are produced in the gut from the nutrients that we obtain from the food that we eat. Okay, so you cannot afford to have some nutritional deficiencies, else we could have a shortage in neurotransmitter production. Also, the gut microbiota play a significant role in neurotransmitter production. So you cannot afford to have a poor gut health. We need a balanced gut microbiome and a balanced neurotransmitters for proper brain functioning. So research has shown that gut disruptors, they tend to lead to depression. Why? Because they tend to destabilize the gut microbiome, and there is a shortage in neurotransmitter production, and thus it leads to depression. Gut enhancers, on the other hand, tend to reduce inflammation in the gut. They help to populate the gut with healthy bacteria that will support neurotransmission, and as such, they enhance proper brain function. So mental health, as complex as it is, it has to be approached in a multifaceted manner. Okay, so apart from addressing it biochemically, it is essential we look out for social support for persons suffering from mental disorders. So that is why I'm presenting to you some psychosocial support group that people can reach out to. They usually offer confidential and psychological emotional support to persons suffering from any form of mental disorders. Next slide, please. So from my evidence-based intervention is what I call a NutriPack. It is a multiple micronutrient supplement all in one pack. The question is it really cost effective? So let's do the cost benefit analysis to verify this. Looking at the metrics, we'll see that the preventive impact of using multiple micronutrient supplements will give us $3.6 million, that is disability adjusted life years over 10 years, okay? And that is a huge reduction. It will give us a reduction in the national burden of depression and anxiety. Looking at the returns on investment as well, for every ~1 we invest in multiple micronutrient supplementation, it will yield 1,000 naira. So the financial analysis is such that we'll have a 1,000-fold return on investment. And looking at the cost per daily abated, that is, it is equivalent to 7,000 naira. And that is a huge low cost to avert 1 year of mental burden and suffering. Okay, so the question now is this NutriPack, the multiple micronutrient supplementation, is it worth it? The answer is yes. It is not only cost effective, it is affordable, it is scalable, and most especially, it is sustainable. Next slide, please. So this is the evidence-based intervention. It's an all-in-one pack, and it contains all the essential minerals and vitamins that will not only help in neurotransmission pathway, they could help to reduce the onset of depression and anxiety. The question is, is it cost effective, okay? Looking at the DALI I presented earlier, right? It is more cost effective to prevent mental disorders from happening than to treat it, okay? So this evidence-based intervention is basically to prevent the onset of mental health disorders, basically depression and anxiety. Okay, so my call to action now is the federal government should urgently integrate this multiple micronutrient supplementation into Nigeria's primary healthcare system, basically to prevent depression and anxiety, improve maternal outcomes, and accelerate our progress towards achieving universal health coverage. It is not only cost effective, it is practical because it can readily be distributed at primary healthcare centers through antenatal clinics, and also it can be distributed to women in underserved communities, basically to prevent the onset of depression before it starts, which is very, very expensive. Thank you for listening.
Thank you so much, Dr. Olufemi, for that wonderful presentation. Let me just use this opportunity to thank all our panelists so far and speakers. Your work is pivotal to advancing Nigeria's universal health coverage agenda. And just leveraging and, just bumping off of what Dr. Olufemi said, truly the time to act is now. It's in the now. And I'm so grateful that, as fellows, we're here lending our voices to the advancement of Nigeria's UHC agenda. We've gotten to a very wonderful time. Thankfully, we've had the opportunity to hear from each and every one of our speakers, and we will be headed straight into the question and answer session. And let me invite my co-moderator, Ayotomiwa Ayodele, who is the Programs Associate for the Women in Global Health Nigeria chapter. I will leave you in her safe and engaging virtual company as she takes the question and answer session. Please do well to engage, and we'll be back in a little bit. Ayotomiwa, please, over to you, and I'll step back a bit and we can go ahead and have our interactive session.
All right, thank you so much. Thank you for the session, for moderating so far, Hadiza. And then good day, everyone, for your time. Okay, so now let's move away from the heavy talks and the numbers and the acts as much as we can. And then we also have a fellow of the EmpowerHER Health Fellowship, and that is Bilkis Abdurrahman Lawal, who is a seasoned broadcaster. She has actually summarized everything that has been said on the call today and painted it in a picture through a video illustration. And well, let me also say that Bilkis is a broadcaster and she is an advocate of gender advocates as well and sexual and reproductive health rights. And she does this through storytelling and using indigenous language. So the video will be seen shortly now is from Bilkis, and it is actually done in Yoruba language because that's where she resides, but it's been subscribed and subtitled to English for our participants. So let's take a look at that. Okay, so I think there's a technical issue there. We are working on it right away. But in the meantime, we might just have to go into the question and answer and take maybe one or two questions while we're trying to sort out the video due to some technical issues. Once I get clarity that yes, we're good to go, we'll play the video. But in the meantime, let's take some questions for our participants here. Okay, no audio yet. We'll work on that. All right, now, Dr. Fumi Adio, thank you so much for the wonderful things you do and for the wonderful work you're doing as well. Let me begin with you. Here. Dr. Fumi, are you there?
Yes, I'm here, Tomiwa.
All right, then. So talking about what you do for maternal and child health, especially in case of emergency obstetric cases. So what role can community health workers play in this effort to achieve and to ensure that universal health coverage is achieved for the vulnerable populations such as rural or low-income communities and have access to emergency obstetric care?
Excellent question, Ayatomiwa. Thank you for that. Okay, so community healthcare workers are very essential when it comes to UHC. Why? Because they are the ones at the grassroots interacting with the people one-on-one. In fact, for the junior community health extension worker, they are supposed to be working in the community for minimum of 80% of their time. So home visits, community mobilization and all that, they are in charge of that. So it's important to empower them so that they can do this work. So first of all, I will always emphasize on prevention, prevention, prevention. So health education, health promotion within the community, very important. When we educate the community, we can get their buy-in into UHC initiatives, that will ensure community ownership at the end of the day. Then another very important thing is that in this our context of brain drain, where health workers are just moving abroad, and then we're having shortage of healthcare workers, it is time to do what we call tax shifting and tax sharing, whereby some of the duties that are being done by cadres that are higher up can be assigned to community healthcare workers. They can be properly trained. For example, in the context of emergency obstetric care, we can train them to do manual vacuum aspiration. We can train them to do manual placenta evacuation, those simple ones under supervision, strict supervision, and with training. Then beyond that, it is also important to know that, like I mentioned, they are the ones working with the people. So we should empower them to carry out follow-up, go into those community, track those children that have not been immunized, track those mothers that are unable to come to the healthcare facilities because of maybe cultural barriers, financial barriers, go to them in their homes and offer this care to them. And then by that, we can bridge that gap between access to care and also obtaining that essential health care. Thank you so much, Ayatomiwa. Over to you.
All right, thank you. Before I let you go, now talking about community health workers. So let's link it up to primary healthcare system in Nigeria. What roles does primary healthcare system play in strengthening or in boosting maternal and child care, especially in cases of emergency obstetric care, like you said?
So I'm glad you asked that question. Why? Because it will help me to elaborate on my call to action.
Okay.
PHC.
And then in
Okay.
40 seconds.
All right. Okay, PHC plays, I'm very passionate about this, so I talk a lot. So PHC plays a major role. Like I said, they are the first point of contact. So we have to look at it in the context of the people that are covered by the services, the essential services themselves, and also the cost of this care. So PHC provides promotive, curative, preventive, and rehabilitative services. So it is important that PHC is strengthened so that people can have access to those services at that grassroots. And beyond that, quality services can be provided to the people by ensuring that our PHCs are present, they are there, they are manned 24 hours, they are fully equipped to provide these services for the people. Let me stop here so that I don't take our time. Thank you, Ayatomiwa.
All right, then. So for our participants, if you have your question, you can drop it in the chat box. Of course, we'll definitely take your questions. And then that takes me to Prudence. While I'll need to check to be sure if our video is ready. Prudence, are you up there now? So
Yes.
we're talking about communication, which is very critical to accessing health, getting the right information. So how do we ensure health communications designers and policymakers actually involve women, especially women at the rural or, let me say, low literacy settings, in creating messages meant for them?
So the key to ensuring women are involved is through meaningful and continuous involvement of women from the very start. I really liked what Doctor was talking earlier, where she was talking about having interactive sessions with the women in communities and all. Through those interactive sessions, you get to actually already communicate this them and find out how to communicate with them from that grassroots level, and not just as a focus group at the end, but through the entire process from the time of conception. When you plan that you want to communicate this to the women, you have to involve the women. This means holding community consultations, working with local women groups, like she said earlier when talking about the PHCs and all, and listening to their experiences, preferences, the barriers they face in accessing health information, everything, finding out, not sitting in a conference room and discussing it alone. Yes, the conference room will happen, but we need to go there and find out what works for them first. We must also make participation practical and accessible. That is, I've seen situations where we've had virtual data, let me say research, where you have meetings with women virtually. What about the women who do not have the internet access? Like we said, like I mentioned earlier, like 75% of people are not online. So we need to use go to them where they are and have these conversations with them. Use local languages, convenient meeting times, and formats that don't require literacy. That is, speak to them in the way they can understand. Everybody does not understand English. You speak to them in Hausa, in Yoruba, in Igbo, however they're going to understand the message. The most important thing is they understand you and they take it. And because when women see that their inputs directly shape the content and format of messagings, they're more likely to trust, use, and even spread the information being given to them.
All right, we have a question here in the chat box, and for our participants, you can also drop your questions or your contributions in the chat box. So for Dr. Olufemi, this is from Farida Amin. She says, "Thank you for this wonderful session. The conversation has been truly insightful. My question is for Dr. Olufemi. Considering the Nutri-Pack for MMS, are you working on a new product, or does the plan involve utilizing the already existing micronutrient brands?" Dr. Olufemi, that question is for you from Farida.
Yeah, thank you very much, Farida, for that question. You see, scientific research is usually in stages, okay? So this is my proposal, okay? It will still have to go through preclinical trials. We're going to do some lab trials on it, okay? So it is not yet out there. So we need to verify the efficacy and the safety before it can be endorsed. However, because my idea is to develop, okay, a flavored granule, okay, ginger lemon flavored granule that will be fortified by all those minerals, okay, and that can be done in the lab. However, for the time being, we already have these things out there, okay, so we can leverage on what we already have. The mineral, we're not reinventing the wheel. We have multiple micronutrient supplementation is all already on in primary healthcare. The point about mine is that I'm focusing my own towards brain health. I'm channeling it to preventing mental disorders. Okay, so that is what I have to say about that.
All right, then. Thank you, Dr. Olufemi. So, Fatima, I'm coming to you at this point. So we're talking about advocacy and asking for the coverage for people, people, sickle cell warriors here. So, but what roles do community-based organization initiative play, and how do we leverage on these organizations to address the unique needs of sickle cell warriors, particularly women and girls? Just as you cited.
Thank you very much, Ayotemura, for that very interesting question. And one of the most I've actually heard today is how, everything at the grassroots level is where, you can get more effect in everything that you're doing. So coming through, community-based organizations, I always say that they are our strongest link to families and culture. They make us understand things that, the realities that women face, where large organizations might not really understand, how big these things are. So when you partner with these community-based organizations, you're able to localize the interventions that you're doing. You're able to organize like local blood drives. You're able to put together like a peer support group within them. Maybe an emergency like transport support, where they're able to take women from primary health cares to maybe secondary to address the issue of transport and access to care, like Dr. Fumi and Dr. Kalu initially mentioned. So I feel like I strongly believe that these groups, can lead conversations and lead, campaigns in local languages. And then these things can, at the end of the day, reduce stigma, help us improve the healthcare that we're talking about. And most importantly, these community support groups can actually support, some economic empowerment initiatives within these women. So ultimately, when we empower these community support groups, we're empowering women so they're able to serve as well. And then that moves us kind of closer to our goal, which is, true health equity. Thank you very much.
All right, then. Thank you so much. So we need to bridge the gap and localize interventions for sickle cell warriors. All right, thank you, Dr. Olufemi. And back to you now, actually. So we're looking at mental health and we're trying to balance it with women's health. How can Nigeria achieve equitable access to mental health care services for all, particularly women and vulnerable populations?
Yeah, thank you very much for the question. For Nigeria to achieve equitable mental health care, where everyone will have access to mental health care, we need to put some strategic things in place. We need to do some systemic checks, okay? So we already have the National Mental Health Policy, which is just on paper. The number one thing, we need to implement that. We need to do a full implementation of the National Mental Health Policy 2023, number one. Number two, we need to integrate mental health care into primary health care, especially in underserved communities. Most of the neuropsychiatric hospitals we have are in cities and urban areas. Most of the people in underserved communities do not have access, okay? And that's, we have a lot of burden in those regions. Then number three, we need to normalize discussion around mental health. People usually think it is very complicated. Scientifically, it is not so complicated as we think, although it has a lot of factors associated with it. We have genetic factor, environmental factors, nutrition, and brain chemistry, okay? So we can manipulate any of these factors and take care of mental health, okay? So we need to start telling people to seek for help, to feed right, so that they can prevent the onset of mental disorders. Because you cannot afford to come down with mental disorders because it is quite expensive to address. And lastly, we need to do some financing around mental health. We need people to have some kind of a health insurance coverage for certain medications, at least, around mental health care. So thank you for that.
All right, thank you, Dr. Olufemi, once again. And let's see, now that we've heard that, we need to speak to mental health issues. Mental health is, we need to normalize conversations around mental health. All right, thank you so much, because we're running out of time. That takes us to our closing keynote address from another UHC actor. But before we do that, let's take the video from Bill Case, and which speaks to everything that we've been talking about since. Okay. Wow, we seems to be having some technical issues today. So sorry for that. Apologies for that. All right, then let me read the profile of our closing keynote speaker for this afternoon, and that is Dr. Olubumi Jetawo Winter. She is a trained pharmacist who has bachelor degree in pharmacy and an MBA as well. She has worked in different health facilities within and outside Nigeria in the last few years, and she's at the forefront of insurance coverage for people at the grassroots, especially in Kwara State. She embodies women leadership as well, because she's a woman, and she's the executive secretary of Kwara State Health Insurance Agency. So she will be taking the closing keynote speech, but unfortunately, she's unavoidably absent. But before we play our video recording, which she has sent in already, there are some questions in the chat box as well, and that is from Ogumbukola Oladipupo. She says, religion to me is the major problem in healthcare in Nigeria. Women in labor goes to churches and mosques and die there most times. Seekers are taken to faith houses too, in crisis leading to irreversible complications. What is being done to address this problem? So, Dr. Fumi Adio, this question is for you, obviously.
Thank you. Oh, Fatima, you want to answer the question?
Oh, no, go.
All right, maybe I will say something, then you would chip in also. So thank you so much, Ogun Bukola, for that question. Excellent question, very valid. And you truly, we see it a lot in our settings, you know, where women go to the churches, mosque, and they just believe that that's where they should go to deliver and all that. But the truth is, this requires behavioral change, right? And for behavioral change to happen, communication is key. So it still circles around what Prudence talked about, communication. When you explain to these women, when you let them know the repercussions of going to these places to deliver, you need to give them evidence of what would happen. If you just say it over your head, they won't believe you. But when you give them evidence of what has happened in the past to women who told that part, they would understand and they would change. So basically, health communication, right, to ensure behavioral change. So we need to keep saying it, and keep saying it through different platforms that we can use, social media, one-on-one, interpersonal, radio jingles, as much as we can. But very importantly, at that grassroots level, we need to meet that woman in that rural area to tell her that, see, this is the reason why you need to be attended to by a skilled breast attendant. And you tell them, if you can speak clearly the importance of why they need to deliver within the hospital setting, they will definitely listen. And once they do that, the rate of maternal mortality will crash. So it is not even only the job of that healthcare worker, but even those of us that know the implication of what it takes for a woman to deliver in a setting that is not hospital and the outcome of it. So it's beyond the work of the healthcare worker, but our work in total to ensure that we keep spreading the news, we keep spreading the word of how important it is for every woman to be attended to by a skilled breast attendant. Thank you so much, Ayatoma. Over to you, please.
All right, thank you, Dr. Fumi. So now let's take Dr. Olubunmi Jetawa Winter's presentation. Thank you. Oh, we seems to be having some technical issues there. And okay, so while we're waiting for that to be rectified, I would call on Dr. Olayinka once again to tell us, okay, what next? And what next are we doing? What's the next steps? What's the next thing from WGH, and what next after all this talk? Dr. Olayinka, over to you, ma'am.
Thank you so much, Ayo, and I hope you guys can see me. It's really been a wonderful. Let me first of all start by thanking everyone that has continued to remain on the call. This webinar was supposed to end at 3:30, but it shows our enthusiasm being on having this discussion. We've heard from our varying speakers on their passion. We've heard stories, they've shared their passion. We've heard the different challenges related to financing healthcare and the role research is playing in shaping policy, and definitely the power of communication. Really, again, as Nigerians, we have that risk perception, our faith is stronger than anything, and we need to acknowledge that when we're dealing with any and everyone. We are religiously inclined, and we can't exclude that. So starting where your audience is continues to be the first priority. What do they know? What are they passionate about? So understanding, and that goes with the role research has to play. So as WGH, we are looking at what's the way forward? What's the way to achieving UHC? It's definitely, there's no single pathway that leads to UHC. It can be built by government alone. It can be achieved by researchers and advocates alone. And it certainly can be driven by just one voice, one leader, or one institution. It's worth a collective power. We need to have women at the driver's seat, looking at discussing the systems, the leadership, and wearing the diverse lens of who is affected, the lived realities of people. So in redesigning the system itself, we need to go with the power of we, that collective action, that collective power. So I'm leaving us with these thoughts in mind. Alone we build programs, together we build systems. Alone, we can make noise, but together we can shape policy. Alone, we lead, but together we change history. Let me also just quickly check, are we able to still project are we able to still project the video?
Yes,
Any
we
confirm?
can.
Yes,
Yes.
Okay, please
Yes.
go ahead and let's hear Dr. Jatao's presentation. Do we want to try that? I'm not hearing any sound.
Okay. Oh. No sound. Okay, let's give it a minute.
It should be coming up very shortly. We'll just play the video.
Wow. Okay, so unfortunately the audio is still bad. Terrible. Okay, apologies for that. Well, it's been a very, very great evening, a great afternoon so far, and the presentation. And from what Dr. Lainka just said, alone we build programs, together we build systems, alone we make noise, but together we shape policies, and alone we lead, but together we change history, which is very, very key. And that is why we are here. So it's not just about the talk. So, Adiza, let me bring you aboard again to wrap up the session. We say thank you for your time and for the presentation to all our panelists, to everybody from WGH, Empower Our Health Fellows, everybody. Thank you so much for being part of this webinar. My name is Ayotomiwa Ayodele, and over to you, Adiza.
Thank you so much, Ayotomiwa, for that. Thank you again to Dr. Olayinka for closing us wonderfully. And again, as Ayotomiwa said, let me still express and extend our gratitude to our speakers, particularly the representative from the NHIA, Dr. Nenaya Kalume. Thank you so much for your presence here, for representing the DG. Thank you to our panelists, our wonderful panelists. You spoke so well, and to participants who joined us today, who asked questions. It's been such a powerful and insightful session, as it promised to be from the very beginning, one that reminds us why conversations like this matter. As we leave, let's carry forward the energy, the ideas, and the commitment to keep raising new voices and supporting women leaders to drive Nigeria's universal health coverage agenda. On behalf of the Women in Global Health Nigeria chapter, thank you all for being a part of today's event. My name is Dr. Hadiza Thompson, although I prefer that you call me Doctor on air. It's been my pleasure to co-moderate this session. And until next time, and there will be a next time, please stay safe, please stay empowered, and stay inspired. Thank you, everyone.